Thank you. I will let me just enlarge my screen here. So hopefully you can all hear me. So welcome and a big thank you to Darchai for sponsoring this session, and some of you will have been in the breakout room and just come back from there. So what we've been tasked with today is to give you an update about cardiology and COVID-19. So I'm going to just share my screen with you now. So a big thank you all for turning up, by the way, on a Saturday morning. So 1 second. Here we are. Okay, so hopefully you should be able to see my screen.
All good, yeah.
Okay, good. I'm not quite sure why it's jumping like that. There we are. Let's just try going in it again. Okay, good. So some of you, some of the names look very familiar. So you know, those of you who don't know me, I work at the Queen Elizabeth Hospital in Birmingham. And what we're going to talk about this morning is ischemic heart disease and how to manage it, particularly in light of the COVID-19 era. So we'll give you a little update about Birmingham, first of all. Many of you will know already that, of course, we're the second city of the UK. We have a population of over 1 million. And in the larger conurbation area, probably up to 5.5 million people. Now, what is important, of course, is population density, and we're beginning to realize this as other parts of the country are becoming or continuing their lockdown, particularly places like Leicester, Blackburn. The population density seems to be an important risk in terms of continuing infection. And our population density in Birmingham is around 3,600 per square kilometre. The average, as you see in the all of England, is 377. But places like Leicester, Blackburn have population densities of over 4,000. So whether or not that's an important factor sort of remains to be seen, but I think this is becoming ever so more important. Of course, Birmingham is a large industrial city, and we have a large ethnic minority population, so particularly people from South Asia and also Afro-Caribbean population as well. So just a quick slide about our hospital. Hopefully many of you will know about us already. We're located in the south part of Birmingham, and since we took over Heartland's Good Hope and Sohail Hospital, we've, under the banner of University Hospitals Birmingham, we've become one of the largest trusts in the country. Now, during the initial first wave, we were lucky because, of course, we have over 100 intensive care unit beds, which makes us the biggest ITU in Europe. We're known for our solid organ transplant program. So if you look at hearts, livers, kidneys, the combined transplant program is one of the biggest, if not the biggest, in Europe. And of course, from a cardiology perspective, we have over 25 consultants working in our institution, and we basically provide a full range of cardiology services. So from complex PCI procedures, including support services with LV support device, impeller. We have a structural program in place with TAVI, PFO, ASD closures, electrophysiology, and pacemaker extraction, and of course our transplant program as well. So why are we here talking from a cardiology perspective? Of course, we all began to realize that there was a problem coming out of China, probably at the back end of December, early January time. And of course, the virus, this novel coronavirus, as it was originally called, we think came from the capital of the Hubei province, which is Wuhan, which is sort of located to the south and east of China. Now, they reported in this paper in The Lancet, which was published in January time, 41 cases of this virus. And the symptoms were quite typical, as we would expect with a virus. Patients were presenting with symptoms of cough, shortness of breath, fever. Elevated inflammatory markers were seen in all of these patients, so CRP, white cell count. There was also a proportion of patients who had leukopenia as well. The other thing that was picked up in these patients was that they had elevated ferritin D-dimers, ALT, which may have been part of the inflammatory process, but a large proportion of these patients also had elevated troponin levels as well. And as you'll see in the coming few slides, this became more and more important as we learnt more and more about this virus. Now, this is a radiograph of a patient who I admitted to our hospital when we all became frontline doctors seeing patients in the ER department, working on intensive care units. Patients were presenting with this bilateral pneumonia, and you can see it was absolutely horrid looking radiograph. It tended to affect the mid and the lower zones predominantly. Almost all patients had bilateral features on their chest x-ray, and many of them, of course, came in with low saturations, although surprisingly some were able to maintain their saturation levels, as was the case with this particular patient, despite having a radiograph that looked like that. So where are we up to in terms of our morbidity cases and unfortunately mortality? These are figures only from yesterday, and you can see we seem to have reached this plateau phase. We are, of course, still seeing deaths in the UK. The recorded deaths yesterday were have brought the total to 45,677. But fortunately, the number of cases that we're seeing have been declining over that period of time. Now, of course, looking back, the peak appeared to have appeared sort of in the early April time, and you can see most of the cases that we were seeing seem to have come around that time. And of course, at that time, we were having daily deaths reaching in excess of 1,000 at one stage. Did we, or could we have done things better? And of course, we heard Boris Johnson only yesterday saying that probably things could have been tackled better, particularly in terms of PPE resources. We knew the virus was coming. The Chinese had shared that information, although some people have criticized them for maybe not sharing that information as quickly as they ought to have done. But our first recorded case officially happened on the 31st of January, but it is possible that we had the virus before that time. And of course, most of our cases were actually coming from Europe. So if you look back, probably Italy, Spain, and France were the sort of culprit countries, which, because we didn't have quarantine rules in place at that time, were bringing the virus into the UK. If you look at the top left panel, you can see that we were essentially 2 weeks behind the Italians. So we had that opportunity to pick up the fact that this tsunami is on the way, but we were probably a little bit slow to react with that. And it wasn't until early March that we saw the coronavirus action plan being shared by the government. And then, of course, we moved to a high level in terms of risk in mid-March. Then a few days later, of course, when we began to realize that we were going to be in some big trouble, the NHS has 100,000 beds. We were told, from the top that we needed to create 30,000 beds, and all non-essential surgical procedures, all non-essential admissions were curbed, so that we could make space in our intensive care units particularly, but also on the ward where we would have to manage these patients pretty quickly. And this, of course, is and was unprecedented. We've never seen anything like this, certainly in my lifetime in the NHS. And of course, our lockdown probably happened a lot later than it should have done, on the 23rd of March, and only now we're beginning to see some easing of those lockdown measures. Where we are at the moment is, of course, that the release of lockdown happened in early July, but we're at the moment in a state where should we be wearing masks all the time for everything? Those things are going to be up for discussion, I guess. How did we fare at the Queen Elizabeth Hospital? So our setup in the West Midlands was different to what was happening down in London. So in London, of course, the Excel Centre was commandeered by the National Health Service with a plan to have ventilated patients transferred to the Nightingale Excel Centre if required. We took a slightly different approach in the West Midlands because we have the biggest intensive care unit at Queen Elizabeth Hospital. The decision was made that if we needed to ventilate patients, we would do so at the Queen Elizabeth site. And you can see from this chart that actually we were the busiest hospital in Europe, with both cases and also ventilated patients. So at the peak of the virus, we had over 700 of our inpatient beds taken up at any stage with patients who had a diagnosis of COVID, and we had reached nearly 200 ventilated patients. And we were told that actually we had capacity for more than double that. So ventilators, you'll remember, were in short supply at that time, but were being manufactured with rapidity and speed, and we were able to get hold of those ventilators. So we certainly had capacity at our institution to increase our numbers twofold. Now, one of the big things about a pandemic is, of course, you can't underestimate the psychological pressures that this puts all of the team members under. And our trust took a decision quite early on that they would perform FFP, filtering face piece testing for the staff to ensure that the masks actually fitted us appropriately. So you can see here on the top right panel in the center of the screen, this is the type of FFP3 mask that most people will wear, but actually that mask doesn't fit everybody. So there are about 30% of individuals who actually do not pass the test when that mask is fitted. And you can see on the bottom left, I was one of those individuals, and I had to be fitted with a slightly different FFP3 mask, which is the type which has a respirator as well. Now, the actual testing itself is quite robust, so it involves you having the mask, and you can see that there's a cable which is attached to that. In fact, there are two cables that come from the computer, one that measures the air within the mask and one which is measuring the air outside of the mask. And the purpose of this is to compare the two to see if the mask is providing any level of protection to the individual. So we had to perform this test with various breathing maneuvers. So during normal breathing, during deep breathing, And of course, when you've got a mask on, you're not keeping still, you're having to move your head around, you're having to talk to colleagues, sometimes quite loudly, because you're working in environments where it can be difficult for individuals to hear what you're saying. And of course, you're having to bend over, attend to patients. So all of these maneuvers are looked at during the testing. And it's only if you pass all 7 of these individual tests that you were signed off then to have that particular mask made available to you. I'd be interested to hear if this was also the case out in your various practices as well. So all of our staff were trained in this manner, but actually the important thing isn't putting on the mask. The important thing is actually what we call the doffing or taking off of the equipment, because that is, of course, the highest chance that you are likely to infect yourself or others at that stage during the process. So what about some data? Well, this is some data that was collected from Oxford. Over 17 million patients were looked at, and at this stage, when this data was published, there was something like 5,500 deaths that had occurred. And what they did was they looked at the risk factors of those individuals who had died. These were all cases of COVID who had passed away, and they tried to tease out to see, what were the important risk factors for individuals. And things became apparent quite early on that there were certain factors that were becoming ever so important in terms of morbidity, but particularly mortality. And this is what this study was looking at. So, and these are things, of course, that we now know, but at that time we didn't know or realize. But there was certainly a disadvantage to being elderly. So you can see that on the forest plot on the top line, the older you were, the higher your hazards ratio for dying. Males didn't perform very well in comparison to females, but important other things that came out from this was obesity, which became a big risk factor, ethnicity, so being Asian or Black doubled your risk of dying from COVID, and deprivation index as well. So if you fell in the most deprived deprivation quintile, then your risk was more than double in terms of mortality. And now, of course, subsequently, what we've also found is that diabetes and hypertension are also risk factors. And of course, some of you may have heard that particular jobs are risk factors as well in all of this. Now, it's difficult to know whether that is to do with ethnicity or deprivation, because a lot of those jobs that are at risk are done by less privileged individuals, unfortunately, within our community. And a lot of those jobs, like security guards, like taxi drivers, are undertaken by people of Black and ethnic minority backgrounds as well. So as I mentioned, troponin became an important marker, and this was data that was published in March in the Lancet. So the original cases suggested that maybe a third of patients had an elevated troponin, and this data took that a little bit further. So they looked at nearly 200 patients, a quarter of whom required ventilation on the intensive care unit. And what you can see on the chart in the red bar are patients who unfortunately die. And if they die, they have elevated troponin level, but not only that, their troponin levels, when they serially measured them, were actually continuing to rise. So there was a big discrepancy in terms of those who survived, who were unlikely to have elevated troponin, and those who died. Interestingly, this became a concern on univariate analysis, but when they performed multivariate analysis, other markers like D-dimers appear to be more important. So this was sort of the first indication that cardiac injury was happening, and having cardiac injury was a bad thing in patients. So, what are some of those putative mechanisms of myocardial injury? On the schematic here, you can see that there were several hypotheses that were being put forward at this stage. Could the virus cause increased risk of what we call a type 1 myocardial infarction, where you have plaque erosion or plaque rupture? There was no evidence of that, and I haven't seen any evidence of that thus far. But what we did see is that there was certainly an increase in what we call type 2 myocardial infarctions. And remember, this is a supply-demand mismatch issue. So the virus itself, a lot of individuals were presenting with hypoxia, with hypotension. We know that there's increased metabolic demands as a result of this, and possibly in individuals who have pre-existing coronary disease, diabetics, hypertensive particularly, we were seeing increasing levels of type 2 myocardial infarctions. Was this sort of an unmasking of the underlying condition, or was it a direct effect of the virus on the myocardium? There are suggestions that the virus was entering the cardiac cells through the what we call the ACE2 receptor. Most of the ACE2 receptors, of course, are located on your type 2 pneumocytes within your lungs, but there are also ACE2 receptors on the cardiac myocytes, and we know that the spike protein virus was entering the cardiac myocytes, or potentially entering via this receptor. So there were theories at that time suggesting that there might be direct viral cardiomyocyte toxicity occurring as well. As I mentioned already earlier, that D-dimers were another factor that was associated with morbidity and mortality in these patients, and you can imagine if there is this inflammatory process that is taking place, that patients will eventually end up with microthrombi. Excuse me. There were few that were seen with disseminated intravascular coagulation. Excuse me. Yeah, there were a few patients, however, who were seen with disseminated intravascular coagulation. Vasculitis and injury to the vascular bed is another potential possible mechanism of injury. And we did, in fact, see patients who had presented with this syndrome, what we call stress cardiomyopathy, or Takotsubo cardiomyopathy, broken heart syndrome. But this, again, was a rarity. Now, fortunately, the dreaded complication of systemic inflammatory response syndrome, which we think is mediated by the interleukin family, was occurring in a small proportion of individuals, but of course was gaining all the headlines. And of course, being in this inflammatory state may itself then cause injury to the myocardium by causing a depression of LV function. Now, this is an interesting case report that was published in the European Heart Journal, where they had a patient who had presented with a stress cardiomyopathy and acute myocarditis. So in other words, elevated troponin, but normal coronary arteries when they had an angiogram performed. Now, in this particular case, what the authors hypothesized was that there was virus which was present within the actual myocardium itself. They did perform a cardiac MRI scanning for this patient, which showed the typical features of myocarditis. But when they went on to do a biopsy, they didn't actually detect any of the genome of COVID-19 within the myocardium, but they were able to demonstrate T lymphocytes, infiltrates, and also edema on the biopsy. So they hypothesized that the acute myocarditis that is happening in these individuals may actually be as a result of direct effect of the virus, although in this particular case no virus was detected, but your virus pickup rate depends, of course, on the size of the biopsy that you perform. And of course, the virus may be affecting the myocardium in a patchy sense rather than affecting every single myocyte. So this is still unproven, but there is certainly some suggestion that we see diffuse lymphocytic inflammatory infiltrates in patients after COVID infection. So the focus originally was on LV impairment, but actually what's becoming more recognized now is that the RV may also become impaired in patients who have COVID-19. So this is 77 patients who were studies actually at our hospital, and this is data that was published last month in the Canadian Journal of Cardiology. Patients with elevated troponins and who were either on intensive care unit or had confirmed COVID-19 on testing. What was interesting was when they had echocardiograms performed, nearly 90% of them had normal LV function, but a quarter of them actually had impairment of their RV function, and 40% of them had dilated RV as well. Now, you could say that actually these are maybe just the findings that you would expect in somebody who is on a ventilator. Not all of these patients were on a ventilator, or maybe these findings are related to the fact that patients had pulmonary emboli, but only a fifth of these patients, or certainly a fifth of the patients who had CTPA investigations performed, were confirmed to have pulmonary emboli. And there appeared also to be an association with this impaired RV function and elevated D-dimers and CRP levels as well. So this is still work in progress, and the next plan is to follow these patients up to see what their outcome has been in the survivors and what the long-term effects are going to be of this RV impairment. Now, of course, during a pandemic, cardiovascular disease, as other disease states, unfortunately do not stop. And what happens is that patients still have and are still affected by coronary syndrome. So STEMI, NSTEMI cases should not drop during a pandemic. The question is how you deal with things, because if your staff are then rostered to be elsewhere. So we had a lot of our staff who, particularly our coronary care unit staff, who nurses who were trained in intensive care medicine, who were seconded to the ITU, and a lot of our clinicians as well were put on frontline rosters, including myself, where we had to provide services to patients coming in through the front door with COVID-19, which meant that actually our staffing for managing patients with acute coronary syndromes dropped. There are also issues in terms of staffing, because at any one time, the original figures that were coming out were that 1 in 5 of your staff may well go off sick or have symptoms suggestive of the virus. So you had to have plans in place to have cover for those individuals. fortunately, we never sort of reached those figures. I think in reality, it was probably closer to around 5%. And as I mentioned already, there was this huge concern about how you manage these patients, because a lot of these patients will require immediate treatment, and that treatment is time critical, so you can't hang around. So you have to perform these procedures in the cath lab with full PPE in place for all staff members. Now, of course, what's important is that these strategies might be different in different parts of the country, and of course, you might have to sort of dial up or dial down depending on what stage you are at in terms of the pandemic, and the numbers being admitted to your hospital. Now, of course, before primary PCI became the mainstay treatment for patients with ST elevation MI, we were using fibrinolytics. So there was a lot of talk, and particularly in China, where the virus started, there was a lot of talk of moving back to treating patients with fibrinolysis. We did have those discussions at our hospital, but we realized actually that the gold standard treatment for patients with ST elevation MI is actually primary PCI, so we shouldn't be going back to fibrinolytic therapy. We know that primary PCI reduces the risk of death, reinfarction in patients, and there's reduced bleeding as well if you undergo primary PCI as opposed to fibrinolysis. There are, of course, a proportion of patients who do require thrombolysis, who then require to come to the cath lab for what we call rescue PCI. So, and that can be up to 25% of patients who are thrombolyzed. So just moving to a fibrinolytic strategy wouldn't have made sense, because 25% of those patients would have probably been coming to your cath lab anyway for rescue. And of course, what became obvious was that there were patients who were presenting with myocarditis, as I've already mentioned on the previous slides. And we know that if you thrombolyze somebody with myocarditis, those patients don't do well at all, and they develop myopericarditis with substantially increased bleeding risk. So the decision was made quite early on that we would continue with managing these patients with primary PCI strategy. We're now beginning to see some of the sort of unintended consequences of COVID-19. So this is on the left panel. This is data that came out from Iran. This was the first country outside of China to be badly affected with COVID-19, and you can see that centers, these are four centers that were performing primary PCI. They saw a substantial decrease by up to 50% in some institutions in their cases, dropping from sort of an average of 400 or 500 cases to down to sort of 200 cases. And this wasn't a phenomenon that was seen only in Iran. This, on the right-hand side, is data that is reported from California, so Northern California. They saw, as COVID-19 infections picked up around March, April time, in the blue line here, when they compared their rates of acute myocardial infarction. This is looking at patients with ST and non-ST elevation MI. They saw a substantial and a significant reduction in cases in 2020 as compared to 2019. So it looked as if patients were scared of coming into hospital around that time. This, however, this phenomenon wasn't something that was ubiquitous. It was in northern Italy, which of course was also badly affected with the virus. They in fact saw a 2.5-fold increase in the number of cases that they were seeing. So These are cases in 2019 in the orange bars here, and in the blue bar, as the virus sort of started to take off in the early March time, they saw this substantial increase in numbers of patients presenting to hospital. And when they looked at these groups of patients, the other thing they found was that in terms of presentation, patients were presenting a lot later. So there was a higher proportion of patients now presenting after 24 hours. Nearly up to half of the patients were presenting 24 hours after their onset of infarct, whereas previously they had presented within sort of 5 to 6 hours. And unfortunately, you can see that had a detrimental effect in terms of mortality. So there was a four-fold increase in mortality in patients who had presented during this pandemic period, probably because they were presenting later. So when in this particular study, they also questioned the patients, and fear of admission was a big thing that was pointed out by pretty much all of the patients who had come into hospital. So remember, a lot of the information that was being put out there at the time was that hospitals should be reserved for individuals who are sick with COVID-19. And unfortunately, the message that the population at large were getting was that if you have any other medical condition, you should probably be staying away from hospital. Clearly, those messages have now changed, and there have been advertising campaigns, certainly from the cardiac perspective, also from the stroke perspective, informing patients that if they still have concerns, particularly with concerns of a heart attack, that they should still be promptly presenting themselves to hospital. And I think part of that also is to do with how we've managed things, and we have to get that information out there that hospitals are a safe place for patients who are not COVID-19 infected. And I'll show you some and share some of our slides on that a little later. So what's our sort of current setup in terms of managing patients with ST elevation myocardial infarction? Well, these patients are brought in the usual manner. For our cath labs, we will treat these patients as suspected COVID-19. We now have a rapid assay that's available. In reality, the assay takes about an hour, the ultra-rapid assay to process, but it means that we can have that information to the cath lab team during the case. But one of the things, of course, we have to remember is that the assay is not 100% sensitive. But anybody with suspected infarct will go straight on the primary PCI pathway, so we haven't changed that. What we have changed, however, is the fact that the staff members all have to be appropriately donned with PPE before the patient is brought to the cath lab. So that has unfortunately meant that there has been a little bit of a delay because staff members have to come in from home for out-of-hours procedures, and they have to be appropriately ready with equipment on before we send for the patient. So this is what our cath lab looks like currently at Queen Elizabeth Hospital, and we have 4 cath labs, and we have the ability of sectioning off part of the cath lab. So there are 2 cath labs behind this screen, 2 in front of it, and any patient who is brought in who is suspected COVID-19 will go into one of these cath labs behind this screen, and you can see we've got this zipper door, if you like, and we have quite clear signs that are put onto the plastic sheeting here to make colleagues aware that this has now become a so-called hot zone, and individuals shouldn't enter here until the labs have been appropriately cleaned and the patient has moved to an area of the hospital where they are managing patients with COVID-19. So all ST elevation MI patients are treated in this manner. Now, the nice thing here is that actually, depending on the number of cases that you're getting through the labs, these labs can be converted to so-called cold labs as well. So as we're sort of increasing our elective work once again, these labs are now being commandeered for elective work. And as soon as a suspected hot case comes in, these then become the hot labs. And these signs are actually quite reassuring for patients as well, because when patients come in, into these cold labs, they can see that the hospital have decided that they will separate the patients quite appropriately, so that there isn't that risk of mixing hot and cold patients. So from a PCI intervention perspective, what we're trying to do with patients who present acutely is that up to 30% of them may well require a follow-on procedure. We're attempting to do that during their index admission, either at the same time or the following day, because we know complete revascularization is beneficial for patients, and it's difficult to predict how the virus is going to be like in 2 or 3 months' time, and it may not be possible to be able to bring these patients back into hospital for follow-on procedures. We've also, during the peak of the crisis, of course, we didn't have intensive care units available for our cardiac patients, but we're now fortunate enough to have no patients on our ITU with COVID-19 at the current time period. So we now have ITU services now available for our cardiac patients as well. So what about sort of considerations going forward? And WHO touched on this very, very early on. Testing is going to be the way forward. So we have screening, which is put in place, and of course we've opened up now once again for cardiac procedures on an elective basis for our patients. And we're asking patients to self-isolate for 1 week along with their family members. They will have a temperature check before they arrive into the hospital, and there are separate doors and pathways for these elective patients. And as you can see, when they enter into the cath lab, there are separate labs which we are using to perform their procedures. We've now moved to more day case work, so a lot of our elective PCI procedures are now being performed on a day case basis. Patients will come in early in the morning, they will have their procedure, and most of them will be able to go home that very same day. And I think this is quite reassuring for patients. What about testing for staff? We have antibody testing available. The results were taking a couple of weeks to come back. They are a lot quicker now. But one of the concerning things was that many individuals who thought they had the virus in January, February time, there was obviously some sort of virus that was going around at that time. Many of those actually tested negative. So from a antibody perspective, what we're seeing is that probably only less than 10% of individuals appear to have antibodies. We don't know whether the antibodies are long lasting or not. It may be that they may well have had the infection, but they don't have antibodies available several months down the line. As I've mentioned already, what we need to have is flexibility in the system. So we're now in that phase, fortunately, finally, that our numbers are really quite low in terms of new infections, but we have to have that availability and flexibility as well in terms of dialing up or dialing down depending on the prevalence of the virus. And of course, as lockdown measures are decreased, we might find that the virus comes back. So, we might find that we're back in that situation where we're having to cancel our elective procedures once again so that we can cope with patients who are coming in with the virus. Outpatients, like most of you, we've now moved to telephone and video consultation. And, we've, in a very short space of time, all become experts on how to use technology and Zoom particularly. So, this is not something that I had even heard of 6 months ago. From a patient perspective, I think they some patients quite like being phoned up. It means that they don't have to come into hospital. There are some patients who we are still seeing face to face, but the number of slots that we have available because of social distancing that we have put in place mean that we're probably less than 20% of capacity. So I think most things can be done over the telephone. From sort of blood testing perspective, there are sites within the city where which have been made available to us, where phlebotomy services can be performed. Things are taking a little bit longer, and it's a little bit more involved even from our perspective in terms of requesting blood tests remotely. We now fortunately have non-invasive cardiac testing available to us. As you can imagine, when we were at the height of the pandemic, CT scanning particularly was one of the first investigations that was removed for pretty much all specialties within the hospital and made available for the medical assessment unit and emergency room for patients presenting with COVID. But the number of patients that we're able to process have reduced substantially. But as patients come in, we are now beginning to request some of these cardiac investigations. And of course, we're a big university hospital. The medical students stopped their studies. The fifth years were quite lucky. They didn't have to take an exam, and most of them graduated without having to need to sit their finals. And they did great work for us because they formed part of the communication teams, informing the relatives of patients who unfortunately were on intensive care unit during the peak of the pandemic. But we're now getting back to that stage where we're beginning to train fellows and registrars once again. But as I mentioned, our numbers filtering through our cath labs are probably around 50 to 60%. So, I'm going to leave you with this final slide. The question is this the new normal? Those of you who are familiar with Birmingham will recognize this is the inside of the shopping centre, the Bullring. This was a picture that I took just a couple of days before the actual lockdown. And clearly you can see that there's not a single soul in the shopping centre on that particular day. Masks for certain occasions, going out, for takeaways, yes. For sit-down meals, no. For shopping in supermarkets, yes. It's nonsensical, isn't it? I think probably masks should be worn by all as much as possible. Of course, the information that we're getting is that these sorts of masks are suitable for the majority of individuals, but as I showed you earlier, from a FFP perspective, you have to be fitted because 30% of people will not fit the mask that is predominantly worn by individuals. What have we learned during the COVID era? And I'm sure this is the case for pretty much all of you, that we're working better in our teams, and we have to be supportive of others. Many individuals are going through a difficult time with family members. they may have had sickness or illness themselves, and we've learnt to grow our family, if you like, in terms of support and offering support to others. And our institution has actually been pretty good, I have to say, as NHS employers go. For those of you who are interested, I produced a video, a day in the life of a frontline cardiologist working in a COVID-19 hospital for the Royal College of Physicians. So that's available. And there's also a YouTube video that I put together with King's College and Manchester, University Manchester's Hospital, talking about rotas and how our rotas were configured and changed, knowing that this tsunami is on the way. Fear is, of course, still a concern, but I'm going to leave you with this saying from Nelson Mandela. Of course, would have celebrated his birthday recently. Courage is not the absence of fear, but actually the triumph over it. So it's all about how you manage that fear, because we are all fearful of the virus, for ourselves, for our family members, for our loved ones, but hopefully with the support networks in place, we will hopefully get over this. Thank you. So I'm, if you can still hear me, I'm happy to take questions if there are any.
You hear me now, Dr. Khan?
Yes, I can hear you. Yes, great.
Sorry about that. So I have a question from a delegate. It is, why is there a higher risk of death in ex-smokers than current smokers with COVID?
Yes, good. I mean, it's a fascinating question, isn't it? I think the thing is that we're not getting the full information about this, and at the moment it looks as if you're an ex-smoker, you're at higher risk, and it might be that actually what's important is your smoking pack history, rather than whether you're smoking and how much you're smoking, whether you're a current smoker. What we know is that cigarettes, obviously, most of what you're taking in is, of course, toxic, but presumably there are some substances within all of that tobacco which are actually beneficial. And of course, it's about teasing out that information. I don't think we'll probably ever get to know exactly the reasons why that is the case. But yeah, it's an important, interesting observation. I'm afraid I don't really have an answer for that.
That's fine. I have another question. What is the sensitivity rate for the COVID-19 swab test?
The sensitivity is probably in the order of about 70%. Right. So certainly, if we have a clinical suspicion that a patient has COVID, we will run a second test. And if you look at the Chinese data, the Chinese were doing 3, 4, even 5 tests on individuals who they had a very strong suspicion of COVID-19. So having one negative test doesn't rule out the possibility you may have COVID. It's only 70% sensitive.
Sample, yeah. Another question's coming. Post-surgery, how long would you expect patients to self-isolate or are at risk of contracting the virus?
Post cardiac surgery or post. Doesn't say. Okay. So what we've said for patients is if they're coming in for surgery, they should probably isolate for 2 weeks prior. So if they're having any form of surgery at the hospital, they should have 2 weeks of self-isolation. Surgery has also been split into high risk and low risk surgery. So those who have high risk surgery, particularly during the peak of the pandemic, my cardiac surgeons were requesting CT scans on all individuals to rule out the possibility of COVID-19 before these patients were taken to theatre. And the reason for that was that there was clear data coming out that if you had COVID-19 and you'd undergone a surgical procedure, you had a huge mortality. So it was important to rule out COVID-19 with 2 swab tests and a CT scan prior to listing for surgery. Post-surgery, I don't think we really have an answer in terms of how long people need to isolate. There hasn't really been any guidance on this, and I think the guidance has to come from government on this, and I think we probably ought to be recommending the standard government recommendations, and if they are considered high-risk individuals in terms of requirement for self-isolation, then they should probably be following those guidances that are out there.
I don't have any other questions. Can you hear me now? No,
yes.
Yeah,
I can.
fine. Yeah, no, that's fine. I've got no other questions come through, so just want to say thank you very much for attending and giving us this speech today. I'm sure the delegates are overwhelmed by the information. Oh, actually, I've just had one more come through. Sorry about that.
Yes, of course.
Is there any further evidence regarding the effect of being on an ACE inhibitor and COVID?
Yeah, so the original, remember the virus, as I mentioned, enters the cells probably through the ACE2 receptor. So there was a lot of concern that those individuals who are on ACE inhibitors or angiotensin receptor blockers would have increased risk of developing or picking up the virus because of entry into the cells. Subsequently, there's been data which has come out, and this is several sources which suggests that actually patients should continue with their ACE inhibitors and ARBs. So patients should not be stopping these treatments because of concerns of contracting the virus.
Okay, brilliant. Okay, so ladies and gentlemen, we'll now be moving on to our second presentation by our sponsors. Again, it'll be the same thing. I will invite you into a room, and you can decide. You can join it if you would like to. Once again, thank you very much, Dr. Khan, for this talk. It's been amazing,
Okay.
definitely, for sure.
Thanks all.
Thank you.
Hello there. Sounds okay? Can you hear me okay? Yeah? Yeah. Perfect. So I'm just going to share you our the slides that we were discussing. I'm just going to, because we did get a bit of a lag in the presentation previously, and then essentially it's just an open session for any questions really regarding anticoagulation. So I'll just quickly show you this graph again. So we looked at the efficacy for edoxaban, right? So this is essentially the same graph again here. So you can see this p-value for non-inferiority for the prevention of a stroke or a systemic emboli. So essentially it met its endpoint as we discussed. And then